Hey everyone, my name's Waj, and welcome again to another episode of The Highest Yield. This episode will be continuing our journey through the lens of the often ordered, yet rarely understood lab tests. With blood work behind us, we'll move on to another classic, urine tests. Before jumping in though, let's remind ourselves of the importance of knowing why we order tests in the first place. Remember that we can split reasons to order a test into the following categories: to screen, to diagnose, and to monitor. If you can't justify ordering a test and come up for a reason that fits into one of these categories, reconsider if you should be ordering the test in the first place. Now with that out of the way, let's get started. Urine. We'll be looking into three major types of tests for urine, and then discuss what comprises each in a bit more detail. These include dipstick urinalysis, lab urine microscopy, and urine cultures. Let's start with the easiest and quickest of the three, the dipstick urinalysis. This is a common screening and or diagnostic tool that is mostly used to detect the presence of certain substances in urine. The presence or abnormally elevated levels of a particular substance can shed light onto what pathologic processes may be occurring in the body. These substances include blood, leukocytes, protein, nitrites, ketones, glucose, and bilirubin. Additionally, the urinalysis can measure the pH of the urine. Finally, remember beta-HCG, one of the most important things to test for in the urine, of course for women. We do this in the ER day in and day out to rule in and out pregnancy. Cheaper and quicker than serum HCG actually. Let's go into a bit more detail with normal values and what deviations in each of these values tells us. First up, as you may not be surprised, blood shouldn't generally be in the urine, and so normally this should be negative. Elevations can be due to a number of processes and should warrant further investigation. Some common causes are listed. Leukocytes are measured by proxy, and what's actually detected is leukocyte esterase activity, an enzyme that's released from lysed white cells. Normally there shouldn't be any leukocytes in the urine, but if there are any present, it's termed pyuria, and is indicative of inflammation that could be happening for any variety of reasons, but most commonly due to a UTI. With protein, remember that the glomerulus of the nephrons prevents filtration of large proteins. Therefore, normally there shouldn't be any proteins present in the urine. However, if there is proteinuria, it's mostly indicative of some renal abnormality or pathology. This may include nephrotic syndrome or glomerulonephritis. Other causes can also lead to protein in the urine, including some drugs. Most often, however, a renal pathology is at play, so start there. Nitrites are end products of nitrate metabolism by gram-negative bacteria. In essence, it's a surrogate marker of bacterial presence, and therefore a urinary bacterial infection. Ketones are end products of fat metabolism that'll be present in larger amounts in cases of starvation or in diabetic ketoacidosis. Aside from these cases, you may see ketonuria with alcoholism, hyperthyroidism, insulin overdoses, dehydration, and with some use of medications like isoniazid. With normal kidney function, all glucose should be reabsorbed, and so presence of glucose in the urine warrants further investigation. You can expect to see glucose in the urine in patients with hyperglycemia, usually secondary to diabetes, or abnormalities in renal tubular function. Bilirubin should also not be present in the urine, and its presence can indicate several different potential pathologies. Things you should keep in mind include liver disease and biliary tract obstruction. You'll also want to see the pH of the urine, which should normally be between 5.5 and 8. We won't go into the details, but know that the kidneys play an essential role in acid-base regulation in the body, and so keeping an eye on the urinary pH is worthwhile and can be helpful in diagnosing certain conditions. With the dipstick urinalysis out of the way, let's move on to laboratory urinalysis, also known as urine microscopy. These tests quantify red blood cells, white blood cells, epithelial cells, and can identify presence of crystals and casts. With regards to identification and quantification of the red blood cells, white blood cells, and epithelial cells, the same principles and concepts apply as the presence of these cells in the dipstick urinalysis, so we'll forego discussing it in further depth. We've provided a chart here of just the normal values so you can expect to see. Note that the normal values are measured in number of cells seen in HPF, which stands for high power field. When looking through a microscope, the reference values used are the number of cells you can see under the high power magnification. For example, as you can see here, for erythrocytes, or red blood cells, 0 to 3 seen under the high power magnification is within the normal range. Casts are plugs of agglutinated cellular debris and protein cells that form in the renal tubular system, specifically in the distal convoluted tubule and collecting ducts. We can separate casts into those that don't contain cells and those that do. The presence of casts indicates an issue with the renal tubules, and different types are associated with varying pathologies at different locations along the system. With regards to casts that don't contain cells, those would include hyaline casts, granular casts, waxy casts, and fatty casts. For casts that do contain cells, we'll discuss RBC casts, white blood cell casts, and epithelial cell casts. Let's start with the acellular casts. Hyaline casts are the most common and are solidified mucoprotein that's secreted from tubular epithelial cells. These can be normally present in small amounts, but may also reflect inflammatory processes when increased amounts are present. Granular casts, also quite common, are often associated with chronic renal disease. Likewise, waxy casts are also suggestive of chronic kidney disease, like renal failure. Fatty casts are essentially hyaline casts with fat globule inclusions and are pathognomonic for high urinary protein nephrotic syndrome. Now let's talk about the cellular casts. First up, the red blood cell casts, which if present, is suggestive of an underlying glomerulonephritis, which can be caused by numerous conditions. White blood cell casts are usually thought to be secondary to interstitial inflammation, but can also be present in glomerular inflammation. Epithelial cell casts form due to desquamation of the tubular epithelial lining, and are often seen in ATN. Of course, remember that there are other cases where you'll see these casts presence, but the etiologies we've mentioned here are the ones you'll be most commonly encountering. And finally, let's quickly discuss the urine culture. Remember that urine is normally sterile. Not much to talk about here other than that, but you can in fact culture the urine and determine the etiology for lower and upper urinary tract infections. It's worthwhile to keep in mind that the process of specimen collection can be contaminated from the urethra and periurethral areas. Also, just because you grew something doesn't necessarily mean it's a significant bacterial load. Generally, greater than 10 to the 8 bacteria per liter is indicative of a significant bacteriuria. Yes, reinforcing not to treat asymptomatic bacteriuria is important. Patients must have symptoms to diagnose and treat a UTI. And that's all for this episode, folks. Happy you could join us again. This was Waj, and we'll catch you next time.